Ever stop to think about the sheer complexity happening inside your head right now?
It's pretty incredible, isn't it?
Your neurological system is this incredibly intricate network controlling everything breathing, thinking, moving. But it's also surprisingly vulnerable.
Mm-hmm.
Welcome to the Deep Dive. We explore complex topics and really pull out the essential info you need, efficiently.
And today we're diving deep into the neurological system, our guide. The comprehensive chapter from the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
Exactly. This is such a fundamental area in healthcare. We're talking brain anatomy, spinal cord, how we assess function, the tests involved, and, importantly, how nurses care for people with neurological conditions.
Yeah, our mission today is really to distill that core knowledge, the key concepts, assessment guidelines, procedures, safety protocols, priority actions, even a look at review questions.
All in a way that's clear, engaging, and gives you a really solid grasp of neurological nursing basics. Think practical takeaways. Okay, let's start at the very top. The cerebrum.
Right, the cerebrum. It's the biggest part of the brain, split into the right and left hemispheres.
And they have that contralateral control, don't they?
Exactly, that crisscross pattern. The right brain handles the left body. Left brain handles the right body for both sensory input and motor commands. It's where all our conscious thought, learning, and voluntary actions happen.
And on top of the cerebrum, you've got the cerebral cortex, that outer layer of gray matter.
That's the hub for our higher-level conscious activities. And it's divided into 5 main areas, or lobes.
Let's quickly tour those lobes, like
Yeah.
our source outlines in box 55-1. First up, the frontal lobe.
Right at the front. Think of it as the brain's CEO. It handles executive functions. Crucially, it contains Broca's area.
For speech production, making the words.
Precisely. And the motor cortex for voluntary movement is there too. Plus, eye movements, memory, morals, emotions, reasoning, judgment, concentration, abstract thinking. It's a busy place.
Moving back a bit, we hit the parietal lobe.
This is your sensory interpretation center. Taste, pain, touch, temperature, pressure, it processes all that. And spatial perception too, knowing where you are in space.
Then behind the ears, roughly, the temporal lobe.
Your auditory center. It makes sense of sounds. And importantly, it houses Wernicke's area.
Which is for understanding language,
Yeah.
right? Spoken and written.
Exactly. Broca forms speech. Wernicke understands it. Damage to either causes distinct problems.
Okay, and way at the back.
That's the occipital lobe, primarily for processing visual information. What you see gets interpreted here.
And finally, tucked away deeper.
The limbic system, often called the emotional brain, but it's key for those fundamental emotional and survival patterns, plus learning and memory.
Okay, so that's the cerebrum and cortex, the main command center. But there's more structure underneath.
Mercy.
Let's talk basal ganglia, the encephalon, and brainstem.
Right. The basal ganglia, these are nerve cell clusters deep inside. Their job is to help make voluntary movements smooth and coordinated, like movement refiners.
Then the diencephalon, between the cerebrum and brainstem. 2 key parts there, thalamus and hypothalamus.
The thalamus acts like a central relay station for almost all sensory info, sorting it and sending it on. It's also a kind of pain gate and part of the system controlling alertness and sleep-wake cycles, the reticular activating system.
And the hypothalamus just below it, small but mighty.
Incredibly influential. It regulates the autonomic nervous system, heart rate, digestion. It runs the stress response, sleep, appetite, body temp, fluid balance, emotions.
And hormones too, right? Linking nervous and endocrine systems.
Exactly, through the pituitary gland, a crucial link.
Okay, moving down to the brainstem, connecting the brain to the spinal cord. Midbrain pons, medulla oblongata.
The midbrain at the top helps coordinate motor movements and has reflex centers for vision and hearing. Quick reactions.
And the pons.
Contains respiratory centers, essential for regulating our breathing rhythm.
And the medulla oblongata, the lowest part.
Vital. It connects to the spinal cord, carries all the sensory and motor tracts, plus it has the critical centers for heart rate, respiration, blood vessel diameter, cardiac, respiratory, vasomotor centers, and reflexes like sneezing, swallowing, vomiting, coughing, life support, basically.
And below the brainstem, we have the cerebellum, the little brain.
Its main job is coordinating smooth muscle movement, maintaining posture and balance, and regulating muscle tone. Doesn't start movement, but makes it fluid and precise. Quality control.
And the spinal cord itself extends from the medulla down the back to about L1 or L2.
Critical functions here. It handles reflexes, helps control movement and visceral functions, and it's the main highway for signals between the brain and body. sensory up, motor down.
And it's well protected, right, by meninges, CSF, fat tissue. Inside, it has that H shape of gray matter.
That's right. The back parts, the posterior horns, receive sensory input. The front parts, the anterior horns, send out motor commands. And surrounding that is white matter, the nerve tracts carrying signals up and down.
Let's talk about those protective layers, the meninges.
3 layers. Outermost is the duramater tough, fibrous.
Provides strong protection.
Then the arachnoid membrane, delicate, web-like, holds CSF.
And the innermost.
The pia mater, thin, vascular, sticks right to the brain and spinal cord. And between the arachnoid and pia is the subarachnoid space, filled with CSF.
Okay, CSF, cerebrospinal fluid. Let's get into that. The ventricles and blood supply.
CSF is that clear fluid made in the brain's ventricles. It circulates through the ventricles and subarachnoid space and gets reabsorbed.
Its job.
Multiple roles. It cushions the brain and spinal cord, protects them, and it helps exchange nutrients and waste products. Normal pressure is about 175 millimeter H2O, and there's usually 150 millilo total volume.
And those ventricles, where it's made?
4 interconnected cavities inside the brain. They produce and circulate the CSF.
And the brain needs a lot of blood constantly.
Absolutely. It comes from 4 main arteries, the 2 internal carotids for the front and 2 vertebral arteries for the back.
And they connect at the base.
Yes, in the circle of Willis. It's an anastomosis, a network providing backup routes for blood flow, ensuring the brain gets continuous supply even if one artery is partly blocked. Really clever design.
Okay, zooming down to the microscopic level, neurotransmitters and neurons.
Neurotransmitters are the chemical messengers. They let nerve cells talk to each other. The source lists key ones like acetylcholine, norepinephrine, dopamine, serotonin, amino acids, polypeptides.
Each with specific jobs, influencing everything from mood to muscle movement.
Exactly. And the basic units doing the work are the neurons, the nerve cells.
Made of a cell body, axon, and dendrites.
Right. Cell body has the nucleus. The axon is the long wire sending signals away from the cell body. Dendrites are branches that receive signals towards the cell body.
Sensory neurons go to the CNS. Motor neurons come from the CNS.
Correct. And the synapse is that tiny gap between neurons where the chemical signal jumps across.
Tell me more about the axons and dendrites specifically.
Okay, the axon conducts the impulse away. Think output. Dendrites receive stimuli. Think input. Many axons are covered by Schwann cells, forming that insulating myelin sheath.
Which speeds up the signal.
It does. And the outer layer of the Schwann cell is the neurolemma. Important point. Most CNS neurons don't reproduce after infancy. But peripheral nerves can regenerate slowly if damaged, but only if the neurolemma and cell body are intact.
Okay, and spinal nerves.
We have 31 pairs coming off the spinal cord. They're mixed nerves, meaning they carry both sensory and motor fibers.
Formed by 2 roots joining.
Yes, the anterior root carries motor signals out, and the posterior root carries sensory signals in. The posterior root has a ganglion containing the sensory neuron cell bodies.
And the autonomic nervous system controls the involuntary stuff.
Exactly. Heart rate, digestion, breathing, pupils, 2 branches. Sympathetic and parasympathetic.
Sympathetic is fight or flight. Adrenergic.
Right. Dilates pupils, increases heart rate, constricts blood vessels, relaxes airways, gets you ready for action.
And parasympathetic is rest and digest. Cholinergic.
Yes, generally the opposite effects. Constricts pupils, slows heart rate, dilates vessels, increases digestion, promotes calm.
Okay, great foundation. Now let's shift to how we assess this system. Diagnostic tests, starting with basic x-rays, skull, and spinal radiography.
Skull x-rays can show bone size, shape, fractures, erosion, calcifications. Spinal x-rays look for fractures, dislocations, compression, curvature, degeneration, narrowing. Basic but useful first look sometimes.
And nursing considerations before and after.
Before, you need to support confused or ventilated clients. Immobilize the neck strictly if fracture is suspected. Remove all metal. Note thick hair.
Yeah.
Keep them immobilized until the results are clear. And always, always check for pregnancy before any radiography.
Okay, next up, computed tomography, the CT scan of the brain.
CT uses x-rays and computers for cross-sectional brain images. Can be done with or without contrast. Dye.
What's it good for detecting?
Lots of things. Bleeding, tumors, lesions, swelling, edema, stroke, infarctions, hydrocephalus, atrophy, shifts in brain structures. Very valuable. Need informed consent if using contrast.
What are the key nursing points before and after a CT, especially with contrast?
Before. Check allergies carefully, iodine. Contrast, shellfish. Assess kidney function as the dye is cleared by kidneys. Instruct the client to lie still, hold breath when asked. Need IV access for contrast. remove head objects, check for claustrophobia, explain the scanner noise and possible sensations from dye, warm, flush, metallic taste,
Anything else pre-procedure?
maybe premedication for allergies if needed. And consider holding metformin if using contrast due to a small risk of lactic acidosis. Follow provider orders.
Post-procedure.
Encourage fluids to flush the dye, expect increased urination, monitor for any delayed allergic reaction, check the IV site for bleeding or hematoma, check warmth, color, distal pulses too.
Moving on to magnetic resonance imaging, MRI.
MRI uses magnets and radio waves, not X-rays. It's non-invasive and excellent for visualizing soft tissues like the brain. Great for finding tumors, vascular issues, subtle tissue changes. Often gives more detail than CT for soft structures.
Key nursing considerations before an MRI. It's all about the metal, right?
Absolutely critical. Remove all external metal. Screen very carefully for internal metal, pacemakers, ICDs, certain clips, implants. These are often absolute contraindications because of the powerful magnet.
Ugh.
Use a saline lock for IVs, no pumps in the room. Special pulse oximeters needed to prevent burns. Address claustrophobia, open MRI option. Anti-anxiety meds. Follow specific instructions if contrast is used. And stress the need to stay completely still, sometimes for a long time. Generally avoid in pregnancy, especially first trimester, due to potential fluid heating.
And after the MRI.
Usually resume normal activities. Expect more urination if contrast was used.
Okay, next, lumbar puncture or spinal tap.
Involves inserting a needle into the lumbar subarachnoid space, usually L3, L4, to get CSF, measure pressure, or inject something.
Big contraindication, though.
Yes, increased intracranial pressure, ICP. Removing CSF when ICP is high could cause brain herniation, very dangerous.
Nursing care for lumbar puncture.
Before, empty bladder. During, position client on side, knees to chest, chin to chest, opens vertebral spaces. Or sometimes prone if guided by imaging. Assist provider, label specimens in order, use strict sterile technique.
Post-procedure.
Monitor vital signs, puncture site for leakage or bleeding, neurostatus, especially headache, position client flat as prescribed for several hours to prevent CSF leak headache, encourage fluids to replace CSF, monitor INO, hand deliver specimens to lab stat.
Let's talk about cerebral angiography now.
This visualizes brain blood vessels. Inject contrast dye, usually via a catheter threaded up from the femoral artery in the groin to the carotid arteries. Shows aneurysms, stenosis, blockages, AVMs.
Nursing actions before and after. Seems like a lot of checks.
It is. Before. Informed consent. Check iodine shellfish contrast allergy. Ensure good hydration beforehand. NPO for 4-6 hours. Get baseline neuroassessment. Mark peripheral pulses. Remove metal. Give pre-meds if ordered.
And after the angiography.
Frequent monitoring is key. Neurostatus, vital signs, neurovascular checks of the leg used for access, pulses, temp, color, sensation until stable. Watch for neck swelling or swallowing difficulty. Notify provider immediately. Bed rest, usually 12 hours. Head of bed elevation depends on provider orders, may be slightly up or flat if femoral artery used. Check peripheral pulses often. Apply pressure dressing or sandbag to site,
Right.
maybe ice. Encourage fluids to flush contrast.
Okay, electroencephalography, EEG, recording brain waves.
Right. Electrodes on the scalp pick up the brain's electrical activity. Used mainly for seizure disorders, sleep studies, evaluating coma, or brain death.
Prep for an EEG.
Hair needs to be clean, no products. Reassure the client electrodes record they don't deliver electricity. Usually need to withhold stimulants like caffeine, maybe some meds, antidepressants, tranquilizers, possibly anticonvulsants. For 24-48 hours, follow orders. Breakfast is usually okay. May need sedation, especially for kids.
After the EEG.
Wash the electrode paste out of the hair. If sedated, maintain safety precautions like side rails up until fully alert.
Last diagnostic test here. Caloric testing or oculovestibular reflex.
Tests the vestibular part of the 8th cranial nerve related to balance. Helps diagnose cerebellar or brainstem problem.
How's it done? Sounds unusual.
Check the ear canal is clear first. Client lies supine, head up 30 degrees. Gently infuse warm or cool water into the ear canal.
And the normal response.
Should be vertigo and nystagmus, involuntary eye movements within 20-30 seconds.
Yep.
If there's no response or abnormal eye movements, it suggests brainstem or nerve damage.
All right, we've covered anatomy, physiology, and diagnostics. Now let's focus on neurological data collection, the assessment itself, starting with risk factors.
Key risk factors include trauma, hemorrhage, tumors, infection, toxins, metabolic issues like diabetes, lack of oxygen, high blood pressure, stress, smoking, aging, chemical exposure. Quite a list.
And the most sensitive indicator of a problem.
A change in the level of consciousness, LOC. Always pay close attention to that first.
Vital signs are obviously critical in neuroassessment.
Absolutely. Changes in BP and pulse can signal rising intracranial pressure, ICP. The classic, though not always present, signs are increasing systolic BP with widening pulse pressure, slowing pulse, bradycardia, maybe elevated temp, and abnormal breathing.
And those abnormal breathing patterns are important clues, right? Mentioned in box 55-2.
Yes, patterns like Cheyne-Stokes, cycling deep shallow apnea, neurogenic hyperventilation, sustained rapid, deep, apneustic, pauses at end of inhale-exhale, ataxic irregular, cluster breathing. They can point to dysfunction in specific brain areas like the hemispheres, pons, or medulla. Recognizing them is key.
Temperature monitoring is also crucial.
Yes, high temp increases brain metabolism and oxygen demand, worsening hypoxia. A spike might mean hypothalamus or brainstem dysfunction. A slow rise could suggest infection. Needs careful management.
And pupils. What can they tell us?
A lot. Unilateral dilation, one pupil bigger, can mean compression of the third cranial nerve, often from increased ICP. Mid-position fixed pupils suggest midbrain injury. Pinpoint fixed pupils often point to pontine damage, maybe from opioids or hemorrhage. Checking eye movements, extraocular movements, also assesses cranial nerves 3, 4, and 6.
Okay, beyond vitals and pupils, what about motor function assessment?
Look at muscle tone: normal, rigid, spastic, or flaccid. Assess strength and equality side to side. Note if movements are voluntary and purposeful or involuntary like tremors or fasciculations, and watch for abnormal posturing.
Ah, yes, posturing. That's a serious sign. Decorticate and decerebrate.
Very serious signs of deterioration. Decorticate, flexor posturing arms flexed on chest. Legs stiff suggests damage above the midbrain, in the cortex usually. Decerebrate, extensor posturing arms stiffly extended. Maybe legs too, indicates a more severe brainstem lesion.
And flaccid.
No motor response at all, the most severe finding.
Reflex assessment is also standard. Box 55-3 highlights some key ones.
Yes, like the Babinski reflex stroking the sole of the foot. Abnormal in adults if the big toe goes up and others fan out, means CNS lesion. Corneal reflex blink when cornea touched. Tests cranial nerve 5 and brainstem. Gag reflex touching back of throat. Tests cranial nerves 9 and 10, important for aspiration risk.
And assessing for meningeal irritation, important for things like meningitis. Box 55-4 covers this.
Right. Look for headache, stiff neck, neutral rigidity, irritability, light sensitivity, photophobia, fever. Specific signs are Brzezinski's sign flex neck, hips knees flex involuntarily, and Koenig's sign pain and resistance when trying to straighten a flexed leg at the knee. Also watch for altered mental status or motor changes.
We also need to assess the autonomic system and sensory function.
For the autonomic system, look for signs of sympathetic activation, increased pulse BP, dilated pupils, decreased bowel sounds, sweating, or parasympathetic signs: decreased pulse BP, constricted pupils, increased salivation bowel sounds. Sensory function involves testing touch, pain, temperature, and proprioception, position sense. Deficits point to specific nerve pathway damage.
To standardize LSC assessment, we use the Glasgow Coma Scale, GCS. Box 55-5.
Yes, the GCS is crucial. It scores 3 responses: eye-opening, verbal response, and motor response. Total score ranges from 3, deep coma death, to 15, fully alert. A score of 8 or less usually indicates coma. Nurses need to be proficient in scoring accurately.
Now, caring for an unconscious client presents major challenge.
Definitely. Unconscious means depressed cerebral function. Unresponsive causes range from trauma, toxins, shock, hemorrhage, tumors, infection.
Key assessment findings.
Unarousable, primitive or no response to pain, altered breathing, decreased or absent cranial nerve reflexes.
And the interventions. Box 55-6 outlines these comprehensively. Seems like airway is paramount.
Always number 1. Maintain Tatten airway, monitor breathing, have emergency equipment ready, frequent vitals and neurochecks using GCS, positioning usually semi-Fowlers, avoid Trendelenburg, turn every 2 hours minimum, side rails up, strict INO, daily weights.
Nutrition. Skincare.
NPO initially need nutritional support like tube feeds or TPN. Monitor electrolytes. Check gag swallow before any oral intake. Monitor bowel function. Meticulous skincare to prevent breakdown. Frequent oral care. Eye care is vital. Check corneal reflex. Use artificial tears or patches.
What about stimulation and safety?
Assume they can hear, speak normally. Maintain calm environment. Avoid restraints if possible. Use seizure precautions if needed. Passive ROM exercises to prevent contractures. Use footboard splints. Initiate PTOT early.
Okay, let's talk about a critical complication. Increased intracranial pressure, or ICP.
A very serious situation where pressure inside the skull rises, caused by trauma, bleeding, tumors, hydrocephalus, swelling, inflammation.
And the consequences if it's not managed.
It can impede brain circulation, stop CSF absorption, damage nerve cells, and lead to brainstem compression, which can be fatal.
Key signs and symptoms to watch for. You mentioned altered LOC is the earliest.
Yes, altered LOC is often the first sign, then headache, abnormal breathing. Later signs include that Cushing's triad pattern, high systolic BP, wide pulse pressure, slow pulse, vomiting, maybe projectile, pupil changes. Late, very concerning signs are worsening vital signs, motor changes like weakness or posturing, decorticated decerebrate, positive Babinski seizures.
How do we manage increased ICP? What are the nursing interventions?
Treat the cause if possible. Monitor respiratory status, closely prevent hypoxia. May need mechanical ventilation, maybe aiming for a lower PaCO2, like 30-35 mmHg, to constrict cerebral vessels. Maintain normal body temp, prevent shivering. Keep environment quiet, low stimuli. Monitor electrolytes, INO. Fluid restriction often needed, for example, 1,200 ml a day.
Positioning and avoiding strain are key too, right?
Absolutely. HOB typically 30-40 degrees. Avoid Trendelenburg. Keep neck midline, avoid hip flexion. Instruct client to avoid coughing, sneezing, Valsalva maneuver.
And medications, box 55-7.
May include anti-seizure meds, antipyretics, muscle relaxants for fever shivering, DP meds, possibly corticosteroids, though controversial in trauma, specific IV fluids, avoid hypotonic, and hyperosmotic agents like mannitol to pull fluid from the brain.
Surgery.
Sometimes a ventriculoperitoneal VP shunt is needed to drain excess CSF.
Let's touch on hyperthermia next.
Yeah.
Dangerously high body temperature.
Defined as temp over 105 degrees F, 40.6 degrees. Increases brain metabolism, worsens hypoxia. Caused by infection, heat stroke, CNS issues affecting temperature regulation. Signs include the high temp, shivering, maybe nausea, vomiting.
Interventions for hyperthermia.
Maintain airway, seizure precautions. Monitor INO, watch for dehydration. Monitor lungs, heart rhythm. Initiate cooling, cool fluids, cool baths, fans, hypothermia blanket. Prevent shivering during cooling, may need meds for that.
Yeah.
Monitor neurostatus, watch for infection. Hypothermia can mask it, dysrhythmias. Protect skin during cooling.
Okay, now traumatic head injury, THI, a huge topic.
It covers any trauma to scalp, skull, brain. Can range from mild to severe, immediate complications, bleeding, hematomas, increased ICP, infections, seizures, long-term. Personality changes, cranial nerve issues, other deficits depending on damage location.
Types of head injuries, box 55-8.
Classified as open durameter disrupted lacerations, open fractures, or closed. Durintact concussions, contusions, closed fractures.
Hematomas are a major concern after THI. Collections of blood.
Yes, epidural between durascal, subdural between durarachnoid, subarachnoid hemorrhage, or intracerebral within brain tissue. Signs depend on size, location, but often relate to increasing ICP.
So look for changing LOC, vital sign changes, Cushing's triad, headache, and visual pupil changes, maybe stiff neck, rule out spine injury first.
CSF leaks. Exactly. CSF leak from ears, otorrhea, or nose, rhinorrhea, suggests basilar skull fracture. Look for the halo sign on gauze or test drainage for glucose. CSF is positive. Also watch for weakness, paralysis, posturing, sensory loss, seizures.
Critical nursing interventions for THI.
Monitor respiratory status, maintain airway, high CO2 worsens edema. Frequent neurovital checks. Monitor for increased ICP. Elevate HOB as ordered. Protect cervical spine until cleared. Maintain normal temp. Prevent shivering. Check cranial nerves, reflexes, motor sensory. Seizure precautions. Manage pain restlessness carefully. Morphine cautious if ventilated.
What about that potential CSF drainage?
Observe nose ears closely. Notify RN immediately if suspected. Do not clean, suction, or let client blow nose. Loose sterile dressing for ear drainage. Check drainage for CSF. Notify provider if positive. Avoid coughing, straining. Monitor for infection. Prevent immobility complications. Educate family on potential behavior changes.
Sometimes surgery is needed, like a craniotomy.
Yes, surgical opening of the skull to remove blood, tumor, fix aneurysm, etc. Potential complications include increased ICP, bleeding, CSF obstruction, hematomas, shock, hydrocephalus, respiratory issues, infection, fluid electrolyte imbalance, like DI or SIADH. Stereotactic radiosurgery, SRS, might be an alternative for some tumors AVMs.
Nursing care before and after craniotomy. Boxes 55-9 and 55-10 are key here.
Pre-op. Explain procedure, get consent, prepare for head shaving, usually in OR, stabilize client. Post-op. Intensive monitoring vital snare checks very frequently initially. Watch for ICP, LOC changes, motor sensory deficits, aphasia, visual changes. May need mechanical ventilation, hyperventilation. Follow specific positioning orders, varies by surgery type. Avoid extreme hip neck flexion, keep head midline. Quiet environment. Monitor dressing drainage, mark measure. Monitor drains if present, strict I&O, hourly first. Fluid restriction likely. Monitor electrolytes, watch for dysrhythmias. Ice packs for swelling, expect periorbital edema bruising. ROM exercises, administer prescribed meds, anticonvulsants, antacids, steroids, antibiotics, analgesics.
Post-op positioning varies quite a bit.
It does. If bone flap removed, position off operative side. Posterior fossa surgery may be side-lying with pillow support. Infratentorial surgery might be flat or HOB 30-45 degrees per order. Supratentorial, usually HOB 30 degrees to help venous drainage. Always follow the surgeon's specific orders.
Okay, shifting now to spinal cord injury, SCI, devastating injuries.
Trauma disrupts nerve tracts, neurons, contusion, laceration, compression, leads to edema, maybe necrosis, results in loss of motor function, sensation, reflexes, bowel bladder control below injury level.
Common causes, complications.
MVAs, falls, sports industrial accidents, violence. Complications include respiratory failure, autonomic dysreflexia, spinal shock, further damage, death. Most common injury levels are C5, C7, T12, L1.
Complete versus partial injury.
Complete transection means total loss below injury. Partial means some function remains, depends on area damaged. Early treatment is key for partial injuries. Figure 55-2 likely shows different syndromes like central cord, upper limbs worse. Anterior cord, loss of motor pain temp, preserves position vibration touch. Posterior cord, loss of position vibration touch, preserves motor pain temp.
Data collection findings. Box 5511. Depends on level.
Highly dependent on level. Generally, respiratory changes, motor sensory loss below injury, initial reflex loss, spinal shock, loss of bowel bladder control, urinary retention, maybe absent sweating below injury.
What about specific levels? Cervical?
C2, C3, often fatal, respiration. C4 involves diaphragm, phrenic nerve. Above C4, respiratory difficulty, quadriplegia. C5, C8. Some shoulder arm movement possible, reduced respiratory reserve.
Thoracic level.
Loss depends on level chest, trunk, bowel bladder, legs, paraplegia. Autonomic dysreflexia risk if injury is above T6.
Lumbar sacral.
Loss of lower extremity function sensation. S2, S3 is bladder center neurogenic bladder below this. Sexual function also affected depending on level, erection, ejaculation.
Emergency interventions for suspected SCI. Immobilization is key.
Absolutely paramount. Suspect SCI in any major trauma until ruled out. Immobilize on spinal board, neutral head alignment. Monitor airway breathing. Prevent head flexion rotation extension. Maintain traction alignment during moves, hands on head. Log roll only. No twisting sitting. In ED, may need immediate skeletal traction, Tong-Shalot for cervical fractures.
And interventions during hospitalization. It's a lot.
Very comprehensive. Respiratory. Monitor status, SPOS C4+. ABGs, maybe vent, deep breathing. Watch for pneumonia, cardiovascular. Monitor for dysrhythmia, hemorrhage, shock, WT, measure limbs, use SEDs, orthostatic hypotension, neuromuscular, frequent neuromotor sensory checks. Monitor for autonomic dysreflexia, spinal shock, maintain immobilization, pain management, prevent immobility complications, pressure ulcers, contractures, prep for surgery if needed, PTOT collaboration, exercise, splints.
GI, renal, skin. Psychosocial.
GI, check abdomen, bowel sounds, ileus risk. Prevent constipation, bowel program, fiber, fluids, ensure nutrition. Renal, prevent retention, bladder program, ensure fluids, 2L day. Monitor for stones. Skin, meticulous care, term Q2H, psychosocial. Monitor status, encourage expression of feelings, sexual concerns, promote rehab realistic goals, connect with resources.
Need to differentiate spinal shock and neurogenic shock. Box 5512.
Spinal shock is temporary loss of all function below injury right after it happens. Lasts days, weeks. Monitor for hypotension, bradycardia, absent reflexes, urinary retention, support vital functions. Monitor for reflex return, end of spinal shock. Neurogenic shock happens with injuries above T6. It's due to loss of sympathetic tone causing massive vasodilation, pooling, hypoperfusion. Key signs, severe hypotension and bradycardia. Needs fluids, vasopressors.
And autonomic dysreflexia. Also box 5512. A neurological emergency.
Yes, very dangerous. Occurs after spinal shock resolves, injuries above T6. Triggered by noxious stimulus below injury, usually full bladder or bowel. Uncontrolled sympathetic surge causes extreme hypertension, stroke risk. Bradycardia, severe headache, flushing, sweating above injury, goosebumps below.
Priority actions for autonomic dysreflexia.
Sit patient up immediately. Raise HOB. Loosen tight clothes. Check for cause bladder distension, bowel impaction. Remove the stimulus quickly. Check catheter, gently check for impaction. Administer antihypertensives if needed. Document everything.
Cervical traction is used for stabilization. Skull tongs and halo devices.
Skull tongs, Crutchfield, Gardner Weld. Insert into skull, weights attached. Keep weights hanging free, ropes clear. Maintain alignment. Pin site care, crucial, infection risks. Halo traction uses a ring fixed to skull with pins attached to a vest, allows more mobility once stable.
Care for halo traction.
Monitor neurostatus, never move client by halo device. Check vest tightness, 1 finger under. Check skin under vest, sterile pin care. Box 5513 covers client teaching pin vest care, infection signs, body image support.
Interventions for thoracic lumbar injuries.
Bed rest initially, maybe body cast. Watch respiratory GI issues or brace corset when mobile.
Surgery for TLS injuries.
Maybe decompressive laminectomy, remove bone to relieve pressure, or spinal fusion, bone graft for stability. Sometimes with instrumentation, rod screws. Post-op care involves monitoring respiratory, vital signs, neurocirculatory status of legs, breathing exercises, fluids, electrolytes, preventing immobility issues, flat position as ordered, cast care, log rolling, pain meds, NPO until bowel function returns, monitor INO nutrition.
Key meds for SCI. Dexamethasone, dextrin, baclofen.
Dexamethasone steroid for anti-inflammatory edema reduction, but use is debated. Dextrin, plasma expander, to improve cord blood flow, treat hypotension. Baclofen, muscle relaxant, to control spasticity in upper motor neuron injuries.
Okay, let's discuss cerebral aneurysms.
Yeah.
Weak spots in brain artery.
Exactly. Weakened wall dilates can rupture, causing subarachnoid hemorrhage. Symptoms might include sudden severe headache, eye pain, vision changes, tinnitus, weakness, stiff neck, seizures.
Interventions. Aneurysm precautions are key. Box 5514.
Yes. Maintain airway, suction only with specific order. Give oxygen. Monitor vitals. Control hypertension. Avoid rectal temps. Implement aneurysm precautions. Strict bed rest, quiet dark room, limit visitor stimulation. Restrict fluids maybe, prevent straining, stool softeners, anti-cough. Sedation pain control, DVT prevention. Goal is to prevent rupture or re-rupture. Surgery, clipping, coiling, may be needed.
Moving on to seizures, abnormal brain electrical discharge.
Right. Epilepsy is the chronic disorder of recurrent seizures. Causes vary. Genetics, trauma, tumors, metabolic issues, toxins, infections. Status epilepticus continuous or back-to-back seizures without recovery is a medical emergency. Risk of brain damage.
Types of seizures. Box 5515 covers generalized and partial.
Yes. Generalized, both hemispheres. Tonic-clonic, grand mal, absence, petit mal, myoclonic, jerks. Atonic, drop attacks. Partial focal, start in one area. Simple, no LOC change. Complex, impaired LOC.
Data collection for seizures.
Get history, type, triggers, any warning signs, prodrome, aura. What happens during motor LOC incontinence? What happens after? Postictal phase headache, sleepiness, confusion.
Interventions during an active seizure. Priority is safety and airway.
Absolutely. Ensure patent airway, but do not force anything in mouth. Note time duration. Observe onset behavior. Ease patient to floor if standing. Protect head. Monitor ABCs. Oxygen. Prepare suction, use after seizure. Turn to side, prevent injury, clear area, don't restrain, loosen clothing, note seizure characteristics, provide privacy.
After the seizure.
Monitor LOC, vitals, behavior. Administer meds if ordered to stop seizure, like benzodiazepines. Document everything. Reinforce lifelong medication adherence, need for blood levels. Advise avoiding triggers, alcohol, stress, fatigue, flashing lights. Encourage resources like Epilepsy Foundation, Medic Alert Bracelet.
Now, stroke or brain attack, a major cause of disability.
Sudden neurological deficit due to blocked or burst blood vessel in the brain. Lack of oxygen 10 mins causes irreversible damage, infarction. Edema follows, causing more issues. Diagnosis via CT-MRI mainly. TIA, mini-stroke, can be a warning. Recovery pattern often facial, swallow, lower limb, speech, arm. Carotid endarterectomy surgery might prevent some strokes. Key message: act fast if signs appear.
Caused by blockage, ischemic, or bleeding. Hemorrhage.
Correct. Ischemic thrombosis embolism is more common. Hemorrhagic rupture is often deadlier. Symptoms can overlap, so imaging CT first usually is crucial to guide treatment.
Risk factors. Data collection. Boxes 5516, 5517, figure 553, NIHSS.
Risks: atherosclerosis, hypertension, anticoagulants, diabetes, stress, obesity, oral contraceptives. Assessment is key. Identify deficits. Time of onset is critical. Use stroke scales like NIHSS. Effects are usually contralateral, opposite side. Findings: airway patency priority, pulse changes, abnormal breathing, high BP, headache, envy, facial droop, stiff neck, vision changes, ataxia, dysarthria, slurred speech, dysphagia, swallowing difficulty, speech changes, aphasia, sensory loss, bowel bladder issues, paralysis, weakness, hemiparasitiomyplegia.
Aphasia needs specific communication strategies.
Yes. Expressive, Broca's, understands but can't speak well. Receptive, Wernicke's, can't understand well. Global, both. Interventions: simple directions, one step at a time, repeat names, allow time, use picture boards.
Interventions during acute phase, first day or two.
Maintain airway oxygen. Monitor vitals. BP often kept slightly high, 150-100 for perfusion. Careful suctioning. Monitor for increased ICP, highest risk for 72-agers. Position side lying, HOB 15-30 degrees. Frequent neurochecks. Quiet environment, maybe catheter. Careful IV fluids. Give meds as ordered. Anticoagulants, antiplatelets for ischemic, maybe meds for BP, seizures. Establish communication method.
Post-acute phase interventions.
Continue acute care, regular turning schedule, 2-agers unaffected side, 20 minutes affected. Skin, mouth, eye care. Passive ROM, SCDs. Monitor gag swallow before feeding. Start sips. Thickened liquids often best. Advance diet slowly, easy chew swallow. Sit up to eat, head flex slightly forward, place food back of mouth, unaffected side. Speech therapy, consult vital.
Chronic phase. Focus on rehab and adaptation.
Yes. Address neglect syndrome. Teach scanning. Attend to affected side. Address hemianopsia. Teach scanning. Approach from unaffected side. Place items in visual field. Eye care. Patch for double vision. Increase mobility. Prevent constipation. Fluids, fiber, stool softeners. Encourage expression of feelings. Promote independence in ADLs, assistive devices. Transfer gait training. PTOT speech referrals. Community resources.
Okay, let's discuss multiple sclerosis, MS, a chronic degenerative CNS disease.
Characterized by demyelination destruction of the nerve sheath, affects nerve signal transmission, onset usually 20-40 years old, has relapses and remissions, cause unknown, likely autoimmune viral trigger in susceptible people, exacerbations triggered by pregnancy, fatigue, stress, infection, trauma. Diagnosis aided by EEG, lumbar puncture, shows increased gamma globulin in CSF.
Data collection for MS symptoms are varied.
Very varied. Fatigue, weakness, common. Ataxia, vertigo, tremor, spasticity, SB, lower limbs, paresthesias, numbness, tingling, vision issues, blurred double vision, temporary blindness, nystagmus, dysphagia, decreased pink touch sense, bladder bowel issues, urgency, frequency, retention, incontinence, abnormal reflexes, hyperreflexia, Babinski, emotional changes, apathy, euphoria, irritability, depression, memory confusion.
Nursing interventions for MS focus on management and quality of life.
Exactly. Conserve energy during flare-ups, safety measures, prevent falls, eye patch for diplopia, monitor for complications, UTI, stones, pressure ulcers, respiratory infections, contractures, promote regular elimination training, encourage independence, balance exerciserist, assistive devices, PT speech therapy, teach avoiding triggers, fatigue, stress, infection, heat, cold extremes, encourage fluids, balanced diet, low fat, high fiber, high potassium often recommended, safety for sensory motor loss, bath temp, remove rugs, medication, self-management education, connect with MS Society.
Next, myasthenia gravis, MG, neuromuscular disease causing weakness.
Yes, abnormal fatigue of voluntary muscles. Issue is that the neuromuscular junction nerve impulse transmission fails, usually due to antibodies blocking, destroying acetylcholine receptors, or maybe excessive cholinesterase enzyme activity.
Key signs and symptoms of MG. Weakness that worsens with activity.
That's the hallmark. Also, difficulty chewing, swallowing, dysphagia. Ptosis, drooping eyelids, diplopia, double vision, weak hoarse voice, difficulty breathing, potentially leading to respiratory failure, diminished breath sounds.
Interventions for MG respiratory monitoring is critical.
Absolutely. Monitor respiratory status constantly. Encourage cough, deep, breathe. Watch for respiratory failure signs. Have suction emergency airway gear at bedside. Monitor vitals. Assess speech swallowing. Prevent aspiration, sit up for meals, assess muscle status, conserve strength plan activities around peak energy, often after meds, monitor for myasthenic versus cholinergic crises, administer anticholinesterase meds on time, educate to avoid stress, infection, fatigue, certain OTC meds, medical alert bracelet, myasthenia gravis foundation resources.
Need to differentiate those crises.
Yeah.
Myasthenic versus cholinergic.
Myasthenic crisis is under medication or exacerbation trigger, infection, stress. Worsening MG weakness, increased pulsars PPP, severe breathing difficulty, incontinence, absent cough swallow. Need more anticholinesterase med. Cholinergic crisis is over-medication with anticholinesterase drugs. Causes abdominal cramps, NVD, blurred vision, pallor, twitching, hypotension, constricted pupils, meiosis. Need to withhold anticholinesterase meds. Prepare atropine antidote.
And the edrophonium tensilon test helps differentiate.
Yes. Inject short-acting edrophonium. If strength improves, it's myasthenic crisis, need more med. If weakness worsens or no change, it's cholinergic crisis. Overmedicated, give atropine. Also used to diagnose MG initially, improvement positive. Need atropine ready due to cardiac risks during test.
Okay, let's talk about Parkinson's disease. Degenerative, dopamine depletion.
Affects motor system due to loss of dopamine cells in substantia nigra. Causes imbalance with acetylcholine, extrapyramidal dysfunction, slow, progressive, can be crippling, mental decline usually late.
Classic signs of Parkinson's, the TRAP acronym sometimes used.
Tremor, resting, pill rolling, rigidity, stiffness, jerky. Echinacea, bradykinesia, difficulty starting, slowness of movement, postural instability, balance issues, stooped gait. Also, monotonous speech, small handwriting, micrographia, mask-like face, drooling, dysphagia, shuffling, propulsive gait.
Interventions for Parkinson's focus on function and safety.
Monitor neuroswallowing, high-cal protein fiber soft diet, small frequent meals, increase fluids, 2L day, monitor for constipation, promote independent safety, avoid rushing client, assist ambulation devices, rocking to initiate movement, low-heeled shoes, lift feet when walking, avoid prolonged sitting, firm mattress, maybe prone position, no pillow, good posture. Peach rehab. Anti-Parkinsonian meds, increase dopamine, are key. Educate on timing side effects. Avoid high vitamin B6 foods, can interfere with levodopa. Avoid MAOIs unless specifically prescribed together, hypertensive crisis risk.
Trigeminal neuralgia and Bell's palsy, affecting cranial nerves.
Trigeminal neuralgia, tic douloureux, affects the fifth cranial nerve sensory, causes severe, sharp, recurrent facial pain along nerve path, triggered by cold, touch, chewing, temperature extremes. Bell's palsy affects the seventh cranial nerve motor, causes unilateral facial paralysis weakness, usually temporary, often linked to viral infection inflammation.
Interventions for trigeminal neuralgia. Pain management is key.
Avoid hot-cold triggers, small, soft liquid meals, chew on unaffected side. Medications like carbamazepine, muscle relaxants, sometimes surgery, microvascular decompression, rhizotomy, etc.
Interventions for Bell's palsy. Focus on facial support and eye care.
Facial exercises to maintain tone, maybe sling. Protect the eye diligently from dryness injury, artificial tears, ointment, patch, take eyelid closed. Frequent oral care, chew on unaffected side, reassurance usually resolves.
Final group of conditions: Guillain-Barré, ALS, encephalitis, West Nile, meningitis.
Guillain-Barré, GBS. Acute inflammatory demyelination of peripheral cranial nerves. Often follows infection. Causes ascending weakness, paralysis. Major concern is respiratory failure, needs close monitoring. Recovery slow. Amyotrophic lateral sclerosis, ALS, Lou Gehrig's. Progressive degeneration of motor neurons. Muscle weakness atrophy leads to paralysis. Spare sensus cognition initially. Respiratory failure is cause of death. No cure, supportive care, encephalitis. Brain inflammation, parenchyma. Often viral, arboviruses, herpes simplex, can be bacterial, fungal, parasitic. Causes fever, headaches, stiff neck, LSE changes, neurodeficits. Acyclovir for herpes type, West Nile virus, mosquito-borne virus, can cause CNS illness, encephalitis, meningitis. Many asymptomatic or mild flu-like illness. Severe cases have high fever, stiff neck, disorientation, tremors, paralysis, coma. Supportive care, prevention is key. Repellent, avoid dusk dawn, eliminate standing water. Meningitis, inflammation of meninges, bacterial emergency. Viral, fungal, causes fever, severe headache, stiff neck, neutral rigidity, photophobia, positive Kernig's-Brudzinski signs, maybe rash, meningococcal. Diagnosis via CSF analysis, lumbar puncture. Need isolation precautions depending on type. Bacterial requires droplet. Monitor neurostatus, ICP, seizures, antibiotics for bacterial.
The source finishes with review questions and a critical thinking scenario. What's the gist?
The review questions test understanding of seizure care, post-CT nursing, ICP signs positioning, head injury prevention, identifying CSF, cervical collars, concussion follow-up, post-craniotomy positioning, traction care, Crutchfield halo, autonomic dysreflexia management, and lumbar puncture positioning. Good self-check. The critical thinking scenario involves a stroke client with unilateral neglect. The answer highlights safety first, check neglected side for injury, safe environment, notifying the RN, and teaching the client compensatory strategies actively using touching both sides, attending to affected side first, and scanning visually if hemenopsia is present.
So, wrapping this all up, we've journeyed through the neurological system, structure, function, common problems, how we assess them, and the critical nursing care involved.
It really gives you a sense of the complexity and, honestly, the importance of this system. Understanding these fundamentals is vital for anyone in healthcare or even just curious about how we work.
Absolutely. It's intricate, and when things go wrong, the impact is profound. Thinking about everything we covered, what specific part really caught your attention, you the listener? Was it the brain's plasticity, the chemical dance of neurotransmitters, the protective systems?
Maybe that's something to explore further on your own time. Could even be a topic for another deep dive down the road.
Thank you for joining us on this deep dive into the neurological system.
Thanks for listening.